I thank Dr. Banavli, sir, for inviting me. And I actually thank the entire organizing team because I was told that there is no event organizing company. The entire event is planned and orchestrated by the Tata Hospital doctors themselves. I think that's a huge thing. We all have organized conference and we know how difficult it is without any event company to organize. I really congratulate them. Before I start the debate, I think this is probably the first debate in my life where I genuinely want my opponent, Dr. Randeep Singh, to win. Because it's a new concept. We all have had patients in our clinic who's doing so nicely on chemotherapy. Bloody one PET CT shows one subpleural nodule, and we have to label it as a progressive disease. So I'll be very happy if Randeep sheds some light on that. That's why I have not touched his side of the topic. I was told to talk on age-old wisdom of tumor shrinkage, as Pankaj Bhai said. So I'm going to talk on that. The moment we all think that metronomic chemotherapy means palliative, I think they should not be sitting in this auditorium. Metronomic chemotherapy is a new concept, does not mean that it applies only to palliation, which I am crystal clear in my mind. Let's take a step back and think, what is metronomic chemotherapy? Like I asked the question, does it change the biology of the disease? Does triple negative breast cancer change as triple positive breast cancer by metronomic chemotherapy? No. We are dealing with the same tumors. We are dealing with the same tumor biology. Why do we want to think different? Yes, of course, it changes the biology of the body. It changes so much of host factors as we have seen. But why should we undermine particular efficacy of a metronomic chemotherapy which can give us cure? Let's digress little away from cancer. We have a patient who is a symptomatic diabetic and hypertensive. You give the treatment, patient becomes asymptomatic. But if the patient's HbA1c is 9, are you happy? If the patient's blood pressure remains at 180 by 98, are you going to say, no, patient is asymptomatic, I am fine. Let this BP continue, let this HbA1c continue. Why am I discussing this? MD Anderson Cancer Hospital few years back announced moonshot treatment on 7 cancers to eradicate them. I again repeat, to eradicate them and cure them. What is the moonshot therapy? What is moonshot? John Fitzgerald Kennedy in 1962 said, we are not going to do research as to how to reach moon. We are going to reach to moon. And the entire nation rallied upon his statement. Ultimately, they landed in moon. Now the point is, what is the relevance? My brother Dr. Tushar asked me the same question on the slide. What is the relevance of this moonshot? Just because we have a new concept of chemotherapy and we can't achieve cure through that, should we define new endpoints just to justify our theory, or should we fight and should we achieve cure? That is a question which we need to answer. Response rate or shrinkage can be seen in neoadjuvant, adjuvant and metastatic setting. We all know rhabdomyosarcoma, where the responders versus non-responders, you have such a huge difference in 5-year survival. Is there any doubt in this data? We all have accepted this data. Metastatic nasopharyngeal carcinoma, 70% of complete responders were alive even after 5 years. I put metastatic nasopharyngeal because we all have 2 or 3 cases of metastatic nasopharyngeal who cross 6 years, 7 years, but all of them, if you recollect from your files, are responders. 2001, we knew in a metastatic breast cancer, even if you go on MD Anderson Cancer website, the longest survivors, 20 years and 25-year survivors, are the one who respond to first-line chemotherapy. Let's fast forward to 2016. Very classical example published in Molecular and Clinical Oncology. 80 patients of breast cancer, metronomic versus non-metronomic. Group with metronomic lived longer. CR, PR, SD, both the groups were same. So the response does not correlate with survival, right? But within the metronomic chemotherapy group, responders versus non-responders, this was the survival difference. 33 months versus 9 months. Coming back to 2000, metronomic chemotherapy, where the first publication of metronomic chemotherapy came, PK/PD studies on cyclophosphamide. Patients with lower limits of VEGF levels after 2 months of cyclophosphamide had higher progression-free survival. Would you call this response? Let's go a little more behind. After the first time Douglas Hanahan coined the term to Folkman and Kerbel first pioneered the experiments, two main experiments told us that metronomic chemotherapy is here for staying. Cyclophosphamide resistant tumors and sensitive tumors both were eradicated in the lab with metronomic dose of cyclophosphamide. Eradicated, tumor shrinkage, response rate. First clinical trial published in 2002 on metronomic chemotherapy talked of response rate. 2013 systematic analysis of metronomic chemotherapy, 80 studies, 89% had response rate as primary endpoint. What? So much data on response rate. Let us now talk about neoadjuvant setting. Is there anybody in this audience who in neoadjuvant setting would want anything other than CR and PCR as a primary meaningful endpoint? Dr. Banavli sir's data we all have practiced and we all talk about in AML. In acute myeloid leukemia patients, when you give metronomic chemotherapy, you talk nothing but the cure. And the cure means complete remission. It means tumor shrinkage, complete. We talked about Cairo 3 study. If anybody has seen the inclusion criteria of Cairo 3 study, after the initial induction, when they were randomized between metronomic and observation, the groups included were CR, PR and stable disease. I am surprised why non-responders were not included there. Adjuvant setting, metronomic chemotherapy, what would be the endpoint? PFS, OS, again the response rate, makes logical sense. Children, I think I don't need to go into the details of the study. We all know that what is going to be the primary endpoint in children. In conclusion, I have 2 minutes left. Cure with metronomic is possible with CR. Long-term survival in metastatic setting is possible in responders. Leukemias and lymphomas, survival is possible with remission. Children survive more if they respond. Still, and again I'm saying from the bottom of my heart, I would want Dr. Randeep to win this debate because for the simple reason we are looking at a new chapter where we are looking in a different way. Thank you very much.